اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين. So alhamdulillah. So we are at Sapphire, and inshallah our program, we are hoping it will run for half a day. So from now until 2 p.m. inshallah, we will have our first 3 talks in the morning. Then we'll have a tea break. But before the tea break, we'll have a panel where you'll get time to ask your questions to the first 3 speakers, inshallah. And then after that, the tea is served behind because we didn't want people to move around and waste a lot of time. So you serve your tea, you get to interact for around 15 minutes, and then we come back for our second sessions, inshallah. So of note is that we have washrooms when you go out from the door. Kama vile unatoka huko nje, just after the stairs on your right. We have washrooms over there. So inshallah, when you need to visit them, they're over there. Don't get confused. And in case you are confused, the ladies who have haya maua twaita vikuba, sio? So utawauliza, they know where they are. Sawa? Haya. So for now, we'll start with our first presenter. Our first presenter is Dr. Janbibi Yusuf. Dr. Janbibi Yusuf Mohammed is a consultant psychiatrist with 4 years experience. Also the medical superintendent at Port Reitz Mental Hospital. So she studied medicine at the University of Nairobi and later specialized in psychiatry at Moi University. She's mostly passionate about helping women understand their mental health, manage stress, and feel comfortable asking for support. For Dr. Janbibi believes that mental health care should respect people's cultural and spiritual beliefs while also using modern medical knowledge to support healing. Do we all believe in mental health? Yeah, we do, right? We know that if our mental health is down, activities haziendi vizuri. You'll be at work, but your brain will be somewhere else. So even giving care to your patients or listening to your clients becomes a problem, right? So through her work, she hopes to break stigma, encourage open conversations, and remind us all that it's okay to seek help. What tunasema, it's okay not to be? Okay. It's okay not to be? Okay. Yes. So we need to take care of our minds just like we take care of our bodies. Sawa sawa. So we are welcoming onto the stage Dr. Janbibi Yusuf to give us the talk on finding hope, healing in the midst of modern parenting struggles. Najua kama wewe si mzazi, you are planning to be a parent, inshallah, si ndio? Ama generation ya sai twasema we don't want children. How many of us have children? How many of us don't, but they want to have children? MashaAllah. So, whole nzima. So, inshallah, we all become better parents to our children so that we can give them better foundations. Sindio? Hi, Dr. Janbibi, welcome to the stage. So there's a board hapa. So when you take pictures, we are in the modern era, the technology era. So please tag us, tag our sponsors, so that inshallah next time they will come back bigger and better. So let's make sure our Twitter and Instagram and WhatsApp are raving with this event. We want to hear it. Wanasema nini? Hebu nikumbusheni. Trending. Yes, please. Thank you. Karibu, daktari.
Shukran. Assalamu alaikum wa rahmatullahi wa barakatuh. Now, most of us think of biological parents when you see a topic like this, but the truth is a lot of us take care of children in one way or another. I would give an example of my house help. She does not have kids of her own, but she has taken care of my kids from their birth up to now, and she's definitely a parent. So it's quite a privilege to be here to talk on a topic that touches me personally because of the things that I encounter in my practice. So how do we find hope and healing in the midst of modern parenting struggles? Guys, what is different? I don't know if we have very young Gen Zers, perhaps, who grew up in this era, but majority of us grew up in that era. That was our childhood, but this is the current childhood. And you can see how vastly different it is. In fact, it's so annoying that even board games and card games are now online, right? Like you can find a group of kids playing Ludo, but they're playing it online. That is how annoying it has become. So society has shifted from analog to digital. Face-to-face communication has reduced. Physical books and libraries are almost becoming a thing of the past. I mean, which kid now will you find on the floor with a bunch of books doing research? Everyone is on a laptop or a tab where information is much easier to get. Outdoor play and community interaction has markedly reduced. Plus, the beauty of the past is that we had limited access to information, you know? But nowadays, you have kids coming and talking about vacations in cities you've never even heard of because of a video that they watched on YouTube. And now they have the same expectations. A city that you've never even heard of, right? Comparisons that are not even applicable because of what they see online. So smartphones and social media, instant access to information. We had to search and search and search, sometimes ask our elders for information. But nowadays, we all know how difficult it is to lie to your kid, do we not? And it's because they'll just look it up and see that mom is lying. Online learning and entertainment, plus virtual social interactions, which have greatly affected how people communicate. Those who actually have kids, and you are seated somewhere nearby, perhaps you are, unfortunately, even most of us, we are on our phones rather than on a book. Sometimes, do you understand what they are talking about? Do you get it? Most of us actually don't. I usually come home and my kids are in the living room and my son has this tendency of screaming, I'm dying, I'm dying, I'm dying, but he's dying on Roblox. Sometimes I'm like, oh my God, I feel like I'm not superstitious, but I'm like, that's bad luck. Like either stop dying on the game or like use another word, but he's screaming, I'm dying, I'm dying, I'm dying, but it's on Roblox. And then they keep talking about my house, I've bought this and my house is this and these dollars, and apparently it's their houses on Minecraft. And I'm like, oh my God, I wish you would spend more time on studies. Then we could have the actual house in reality rather than this beautiful, expensive house that you have on Minecraft. If your child today were to make a mistake, would they come to you? Would they open up? Or would they be terrified of your reaction? And if the answer to that is that they would be terrified, the unfortunate truth is that that mistake goes from this to this, because they'll end up seeking advice from the wrong people. The world has changed, and that is why parenting has also changed. Technological advances and societal changes have transformed childhood the way it is right now. But change is not always bad. So there are new opportunities. There are things that we can take advantage of. There are ways in which life has become easier, and that's a good thing. But unfortunately, there are also challenges compared to the previous generations, especially for those of us who cannot adapt. So the digital shift is not all bad. I mean, even we have easy access to parenting information. I may not necessarily need to go to the doctor to see if my kids' milestones are okay. I can search it up, search several websites, right? I can search advice on how do I do this and how do I do that. I mean, don't we all love it that we can communicate with teachers instantaneously? That alerts are sent on our WhatsApp group, and now you are sure your kid cannot lie to you whether there was an assignment and so on and so forth, because you as a parent also saw it on a WhatsApp group, that you can reach your doctor, pediatrician almost immediately. Isn't that amazing? Educational resources available at home. We don't have to buy as many books as people did in the past. And all that is because it's all available on that piece of device. The ability to stay connected with children remotely. Your kid has gone on a trip and they can send you a text. You know, your kid is, the older ones, is out with their friends and you can give a call, check in on them. So that's amazing. Exposure to diverse cultures and ideas. They can learn more. They can see how vast and diverse the world is. And this can enable them to respect other people's cultures and ideas. Now, what are the challenges? Excessive screen time. And this is not a challenge just for our children, let us be frank. It's a challenge for ourselves too. Cyberbullying, exposure to inappropriate content, reduced face-to-face social interaction. How many times do you find you are in a room with a group of kids, they are not looking at each other, they are all on their tabs, they are in a virtual space, it's an online game where they are all together playing. So in a way they are together, but they are on their tabs and they are not looking at each other. They are just interacting in a virtual space. Sleep and attention difficulties. I mean, this is exposure to light, exposure to stimulation. And thanks to the modern YouTube shorts and TikTok videos, it's like kids spans, 20 seconds, a minute? How many parents feel like they hear their kids saying, I'm bored, way more frequently than we used to complain that we are bored? Is it just me? How many times, like, I'm bored, 20 minutes, I'm bored, and it's like you get tired of figuring out how to stimulate them next. Which game should I give them next? Digital addiction and online dependency. I mean, how many kids throw a tantrum if you take away their tab? If you put a limit to the screen time? And again, unfortunately, this applies to us too. How many of us can do a day without the phone? And you are not on call, you're probably on holiday, you know? How many of us can do a day without the phone? Like, let's be honest. I'm glad you can, Doc. So unfortunately, we've gotten addicted too, but it's way worse for our kids because of their developing minds. And of course, the rise of AI, artificial intelligence, and all the questions that it poses. And I felt like I had to explain artificial intelligence further. So with time, we are noticing an over-reliance on AI, which reduces problem-solving and thinking skills. Kids don't want to look up something in their book. They just want to ask AI and get the answer instantaneously. And unfortunately, they are also under this idea that AI is always correct, which is not the truth. Despite even AI putting it down there, sometimes the information can be inaccurate, blah, blah, blah. There's this perception that AI is always correct. So there's a lot of misinformation and bias. And again, if they can't think critically, how do they evaluate whatever information they're receiving? There's loss of creativity and effort. The easy access reduces opportunities for children to struggle, to explore and learn. It's because whatever you need, you are getting it instantaneously. Something that was not the norm in our case. You remember how research, especially those of us who are older, the millennials and above that, you remember how it was to do research. You know, you have a bunch of books, you're exhausted. You've used like 2 hours and you have like maybe 10 minutes worth of information. Whereas if I use AI, I can have my slide done in a day. In fact, done for me. Privacy and digital safety. Children also need awareness of what they share online and how their data is used. Unfortunately, we really need to teach them what can be shared and what cannot. And again, for you to teach your child, it means you need to be aware. Unfortunately, those of us who have not learned to use AI, you might not be the best person to advise your kid because you don't know what is out there. So in order for you to be able to tell them, you know, you should not do this and you can do this, perhaps don't do this, it means you've also given it a try and you have an idea. Artificial companionship, the illusion of friendship. AI is designed to be nice and agreeable. You'll abuse it and it will tell you, I understand you are frustrated at this moment. Take a deep breath. And you see, kids think like, this is how a friend should be. Which friend will you go out there, tell them something rude, and they'll be like, I understand you're frustrated? That friend will be angry, they'll walk away. So that's how true human experience is. But because most of our kids spend their time online, they think that this is how friendship should be, and there's this perceived notion that I can be rude and someone will be understanding, which is not the case. So it actually reduces those interaction skills. Plus, AI might seem nicer because it always agrees with you. But remember, AI has been designed to be agreeable. Plus, AI has only the information that you feed it. So most of the time, we tend to feed it subjective information that favors you. Like my friend did this, this, and that. They were so mean. For those of us who use AI for advice and friendship. And AI will be like, you're right. What your friend did was not good, blah, 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 blah. When you actually didn't feed it the correct information, maybe you are the one that made a mistake, and your friend's response was appropriate. And you end up losing a friendship because of misadvice. So we have new responsibilities. We have to monitor online activities. We have to teach digital literacy. And in order to teach digital literacy, you have to be digital literate. We need to set healthy screen time limits, promote online safety, and encourage balanced online and offline activities. And again, I repeat, in order for you to do all this, you have to be digitally literate. How society has changed. What are the modern family realities? We have smaller family units. Most families that live nowadays are nuclear families, all right? So there's an increased parenting burden and stress as opposed to those members who used to live as an extended family, where your mom would probably help you, your dad could help you with something. Reduced intergenerational guidance and limited community involvement and child supervision. Now, on top of that, most families are nowadays dual income families. So mind you, you are less adults in the house, and then most of the adults are too busy. I mean, there are opportunities that come with that. Financial opportunities. Your kid can go to the best school. Isn't that amazing? You can afford the things that your own parents could not afford for you. But let's be realistic. There's less time available for direct parenting. There's greater reliance on schools and childcare services. And I believe most of us in this room are working one way or another. Okay? So there are challenges with that, but of course adaptability is important, like finding good childcare services and perhaps finding a good school. But it's important not to over-rely. You need to have that time for direct parenting. Urban living. There's less space for outdoor play and exploration. People explore things on their tabs now, don't they? Through the same Roblox and other games. Yeah? They are usually just exploring literally in their tabs. Increased concerns about safety, traffic, and crime. And there's reduced interaction with neighbors and the wider community. Majority of us don't even know our neighbors nowadays. So you can imagine how complicated that is for the kids. Greater mobility and migration. Fathers that have to work away, sometimes you yourself. I mean, how many of us have gone to study leave and had to leave our children and so on, and they've had to adapt to that. Changing gender roles. I mean, we have stay-at-home dads now, don't we? So things are changing. I cannot go to work and cook and bath the kids and all that. So negotiation of who's responsible for what is important. More diverse family structures. We have single-parent families, blended families, right? Grandparents-led households. There are those of us who went to study, and thank God our parents helped us a lot. Co-parenting arrangement. There's also changing values. In the past, we were supposed to be obedient. You are told something and you don't question authority. Collective responsibility. You always think of the family, the community, and the group. Today's focus is independence, self-expression, emotional well-being, and critical thinking. So don't be surprised when you tell your child something and they ask you why. And you're like, what do you mean why? Because I said so. But that answer is not good enough for them. They want the logical reason of why. So the modern parenting landscape is increasing in complexity and the pressure to get it right. In the past, it was mostly about behavior, but now it's, is my child okay psychologically? You know, we've all heard of childhood trauma, and we are all worried, are we causing them that childhood trauma? There's more information, yes, but there's also more confusion. More information gives you a paradox of choice. So who is right, who is wrong? The comparison trap through social media. You know, I encountered this in my kids' school group where the teacher actually decided to send photos of the kids who've done their homework. So my kid plus, I have a colleague that also works, and our kids have not done the homework. We forgot. And that happened like 3 times. And you know, I was like, what is she trying to do? Tell us that you are a bad parent. Does she have no idea that we are working, you know, and so on and so forth? But mind you, I went home and I told my kid, like, the next set of photos, if you are not there, because you're making me look so bad, if you are not there, I don't know what will happen. So there's greater parental responsibility. Again, it's because of, it's more of a nuclear setup right now. And you can imagine for the single parent homes, where now it's one parent doing most of the job, there's higher stress levels, and it's because the environment is stressful for us too. There's need for adaptability and lifelong learning. The generational gap in experience. We are living in the always on culture. The world is always on. And if we think about it, even for us, like before you leave work, it was a landline. You probably didn't have that same landline at home. So no, your boss won't bother you. Nowadays, your boss is texting you on WhatsApp. You are receiving emails at night. You know, the boundaries are obscured. So the always-on culture is the same world that our kids are living in, especially for those who are connected to their friends. Like before, you would leave bullying at school. Nowadays, you go home and you are being bullied past school hours because some friends have decided to form a group, talk about you, and so on and so forth. The relatability challenge. We didn't live in this world. When your child is being cyberbullied, how do you relate to that when maybe the only bullying you know is the physical kind? You know, we may tend to dismiss their concerns like it's not that bad. Just ignore it when actually it's affecting them a lot. So how do we make it a bit easier? Focus on connection over control. You cannot control the digital world, but you can control how your child interacts with it by using boundaries and by making them feel safe. Prioritize some minutes of uninterrupted device-free connection daily. Like not one where your kid is not on a tab but you're on the phone. That is not genuine, good connection. Accept that mistakes will happen. Teach adaptability and emotional resilience. Okay, unanishtua, but sawa, let me fasten up. So teach adaptability and emotional resilience. That is far more valuable than creating a perfect friction-free environment. And it's because this is the reality. The world is changing. The digital era is here, and it's here to stay. Even the only environments I know are the Mormon cultures, like in America, where they live with no devices at all. And even then, if you were to try raise your child in such an environment, they would still grow up, be exposed, and want to leave. So the digital era is here. Change is inevitable. We should enable our kids have that emotional resilience and adaptability to navigate it. So don't pretend that change is not happening. It is. Practice digital boundaries. I feel like I can skip this because most of you are aware of them, and we will share the slides. Yeah? But you know, like curfews for screen time, limited screen time, perhaps bedrooms with no screens on the table. The only thing I should highlight is that it has to apply for the whole family. It cannot be that your kid does not have their tablets on the dinner table, but you have your phone because I'm a doctor and I'm on call. Like, You know, your phone could ring from the living room and you would hear it. And if you are on call, you'll go pick it. So the rules should apply to the entire family. Prioritize your well-being as a parent. Children take emotional cues from us. If I'm stressed and I deal with things with that stress. That is how my child will think is normal. That is normal for them. So ensure you are taking care of yourself so that you can be able to reassure your child. And it's okay to seek support for those who need to. Some of us are going through more than the others. The necessity of listening without judgment. Children don't always need immediate answers or solutions. They just want to feel heard and understood. You know, like if your child is complaining about bullying, before you like I'm coming to school, you know, or you go seek out that kid so that you can tell them off. What is it that your kid wants? Maybe they just want advice so that they can try it out themselves. And please, as a parent, don't try solve all your kids' problems. They should learn to navigate the world on their own. So let them solve some of their problems on their own. Be their listening ear. Try understand what they're going through. Give them advice where necessary. There are some cases where you need to intervene as a parent. So where it is extreme, yes, intervention is necessary. But please be the safe space that your child can trust and feel secure. Now, there is a hadith by the Prophet sallallahu alaihi wasallam. I'll just go to the relevant part, that a man is the guardian of his family and he's responsible for them. A woman is the guardian of her husband's home and his children, and she is responsible for them. Parenthood is a privilege and a profound responsibility. So let us try our best. That being said, we don't influence everything. Okay, the outcome, the character that our child will take is dependent on their genetics. What if you married a psychopath, you know, and you only found out after you were pregnant and the divorce, like you didn't know, so that's not your fault, that's genetics, you know? What if the temperament in the family is, you know, you are all the type that gets, you know, something small and I'm ready to fight. So you are responsible for the microenvironment, the parenting part, the relationships at home, the immediate surrounding. Sometimes we are fortunate enough to control the macro environment. Maybe you are rich and privileged. You can choose a good neighborhood, a good school, but sometimes we don't have those opportunities. And even when you choose a good neighborhood and a good school, there are still things that your kid will be exposed to that you cannot control. And of course, there's free will, individual agency. They still have the ability to make a choice. It could be the right choice. It could be the wrong choice. So let us embrace the wakul in parenting, meaning let us do our part. Let us do our maximum to ensure that our child will be of good character. But we don't have full control of the outcomes. We are limited. We are accountable for our efforts, not the ultimate outcomes. I believe most of us are familiar that with Prophet Nuh's story and the fact that his son did not enter the ark. I mean, could you think of a more perfect parent? He was one of the most patient prophets. He preached for thousands of years, but his son did not enter the ark. I don't know if some of us know Ted Bundy. He was an American serial killer. He killed around 30 women. He had a very normal childhood. Like, there was no trauma, there was no incident, there was nothing. He went to university, he was studying law. I'm not sure if he finished or not, but the guy was a serial killer. So you are not responsible fully for the outcome. That being said, some of us will be deeply, deeply tested through our children. It's not a reflection of poor parenting, neglect, or lack of faith. It's just the test written for you. So don't blame yourself for everything wrong that your child does. Let us love our children without the crushing weight of trying to control their destiny. May Allah grant us wisdom in our parenting, patience in our trials, and make our children a source of joy, righteousness, and ongoing reward for us in this life and the next. Thank you.
MashaAllah, let's appreciate her better. Good. So we've learned a few things. Tusitake kuwapatia watoto wetu kila kitu ambacho tulikosa. Let them work for what they're supposed to get. I know when we go out there and we take up extra shifts and locums and we want to give them all gadgets and all Netflix accounts and take them to every hotel or so at times let them work for it. Let them see that this is something that I've Yani nimejaribu na nikapata, na nimejaribu na sasa sikupata. So I think Dr. Janbibi has passed her information well. Let's think about it. If you have any questions, inshallah, they'll be up here in a few minutes. So we'll go next, next to the next speaker. So our next speaker is Dr. Aisha Ahmed. Dr. Aisha Ahmed is a consultant dermatologist and cosmetologist. So Dr. Aisha works at Likoni Sub-County Hospital. We have noticed that siku hizi there are so many advices about our skin and faces and what to do and what not to do, what kind of skin cares are the best. Everyone is a doctor in that field. Sindio? Yeah, if you don't use sunscreen, you'll utaka kama mzee when you're 30 years old. All these stories are out there. Mambo ya kutumia sijui nini nani. Vitu ni mingi, by the way. So we have Dr. Aisha here. She's also part of Lumia Skin Aesthetic and Laser Clinic. She might tell us what that is. I think it's the modern thing. Atatueleza what this laser thing is all about. So Dr. Aisha Ahmed, welcome to the floor. So Dr. Aisha is going to talk about pigmentary disorders. Let's welcome her. I am sure you have so many questions about the skin. So muziandike, she will be up here for you guys so that you get them answered. Sawa? Haya, karibu daktari.
So, assalamu alaikum. As I was introduced, my name is Dr. Aisha. I work at the Likoni Sub-County Hospital, and I co-own Lumia Skin Clinic. This is an aesthetic center which has newly opened in Mombasa. So this center is, we deal with all aesthetic, of course, consultation in treatment of skin diseases, and then we also take care of aesthetic problems, laser hair removal, and all other skin procedures. So without further ado, we'll start our topic for today. We're going to discuss pigmentary disorders. So pigmentary disorders is a very wide topic in dermatology, other than the common skin. So other than the common skin diseases that we know of, most of the other complaints we get are pigmentary disorders. These are either hyperpigmentations or hypopigmentations. We will dive into two most important conditions that affect our patients, those being vitiligo and melasma. So our objectives for today are those ones. We're going to understand the physiology of skin pigmentation, classify skin pigmentary disorders, recognize the common hypopigmentary and hyperpigmentary conditions, discuss the diagnostic approaches, and review the current treatment modalities. Most importantly, current treatment modalities. And also understand the recent advances in pigmentary dermatology. So in physiology of skin pigmentation, we cannot discuss it without discussing melanin and the role of melanin. That is what gives the skin its color. So you can either have more of it or less of it in specific parts of your body, which will now present with the pathologies we're going to discuss. So for melanin production, melanin is produced by melanocytes in the basal epidermis. Melanocyte to keratinocyte ratio is approximately 1 in 36. So, and melanosomes are organelles which transfer melanin to keratinocytes. So this diagram gives us the levels or the different layers of the skin. If you can remember, we have the epidermis and the dermis, and then the epidermis is made of the stratum corneum, stratum granulosum, spinosum, and the basal layer. So the melanocytes reside in the basal layer of the epidermis, and as you can see, one melanocyte, that's what we're talking about, the melanocyte keratinocyte ratio. One melanocyte there's one melanocyte in every 10 to 20 keratinocytes. So one melanocyte will distribute the melanin to all the keratinocytes around it. So when it comes to classification of pigmented disorders, as I said, there's hyperpigmentation and hypopigmentation. The most common hyperpigmentation condition we have is melasma, and then which we're going to discuss in detail. We also have post-inflammatory hyperpigmentation. This is a very common complaint, especially in children, even in adults. Usually comes after an inflammatory condition, could be something as simple as a eczema, a healed eczema. Can be a disease condition which has healed, like lichen planus, psoriasis. So when they heal, they leave a mark, which is a hyperpigmented patch, a flat lesion on the skin, which can be treated, and sometimes they resolve. We also have drug-induced pigmentations. We have a fixed drug eruption, which is also another common condition. This is caused by drugs, most of the antibiotics that we get over the counter. It's also caused by NSAIDs. Drug-induced, the fixed drug eruption, FDE, usually gets worse. It's usually in the same location, so every time you take the drug, it still hyperpigments within the same location. So you'll have a patch that is not resolving. So once you take the drug that you're allergic to, it tends to hyperpigment but stay in the same location. So if you develop a serious reaction to that specific drug, it can turn to a bullous fixed drug eruption, which can now cascade into a wound, but mostly just a flat patch on the skin. We also have lichen planus pigmentosus. This is caused by lichen planus and is usually found around the forehead. We have acanthosis nigricans. This is a condition that is mostly found in people who are obese, and it's a good indicator of diabetes mellitus. It's also called the dirty neck sign. So the patients will tend to have hyperpigmentation on their necks, which are usually lichenified. Lichenified means the skin lines are very visible when you look at the patient's neck. So you might think it's a dirt and tell the patient shower properly, but it's just acanthosis nigricans. And usually with weight loss and sugar control, it tends to reside. So for the hypopigmentations, we have vitiligo, which we're going to discuss in detail. We have pityriasis alba. This is a form of eczema. Okay, thank you. So pityriasis alba is a sign of atopic eczema. It's usually found in children. It's where they have hypopigmented patches on the face usually. They will have just a patch on the cheeks. Many people confuse it or treat it as tinea fasciae or tinea of the face, but it's different because this is flat and doesn't have any scales on it, and usually treated with steroids. We also have tinea vesicala, which presents with hypopigmented macules and patches. Tinea vesicala is caused by yeast. It's what we call commonly umba in Kiswahili, and these are treated with antifungals. So like post-inflammatory hyperpigmentation, we also have post-inflammatory hypopigmentation. This is when an inflammatory condition heals, but with a hypopigmentation, like with lightening instead of darkening. And of course, we have the most common oculocutaneous albinism, which is a genetic condition that we all know of. So when it comes to these pigmentary disorders, in your diagnostic approach, the most important thing is history. You need to know the onset and the duration of this condition, the progression, any family histories, any drug exposures, and history of autoimmune diseases. In examination, it's important to note of the distribution, the pattern, the color variation, and associated skin changes. And those are some of the investigations that we can do. Examine the skin with a Wood's lamp, a dermoscopy, you can do a skin biopsy, or do further tests. So we're going to dive into vitiligo. Vitiligo is an acquired depigmenting disorder due to melanocyte destruction. So it's the prevalence is 0.5 to 2% worldwide prevalence, and it has an equal sex distribution. Onset is early adulthood, but can begin as early as 5 years of age. We have several children on treatment who have vitiligo. So clinical types, we have 4 types of vitiligo, depending on the section of the body affected. We have non-segmental vitiligo, segmental vitiligo, mixed vitiligo, and universal vitiligo. We're going to see how those are distributed in the body. So it presents with a chalk white macule or a patch. So a macule and a patch are flat lesions on the body. The difference is the size. A macule is a small lesion which is less than 1 millimeter, and a patch is when it's more than 2 millimeters. So they're both flat lesions, and they are surrounded by normal skin. So you will see hyperpigmentation around a very hypopigmented patch or a macule. It's of symmetrical distribution, and you'll also see leukotrichia. This means the hair follicle, the outlet of the hair follicle will also have hypopigmentation or depigmentation. So when it comes to the distribution pattern, we have generalized and localized. The most common is in generalized, the most common one is the vulgaris, the vitiligo vulgaris. This is patches of depigmented skin in generalized parts of the body. So it can be several parts of the body, from the knees, the groin area, underarms, face. We also have acrofacial, which affects the face, of course, and the acral ends of the body, the hands and the legs, the feet. We have universalis, which is the generalized type, of course, but with patches of normal skin. So that it's not confused with vitiligo, this will have patches of normal skin. And then in the localized, we have two types, focal and segmental. Focal is a patch of depigmented skin on any part of the body, of course smaller than segmental. So segmental will be a wide part of the body but does not cross the midline. So it stays on one side of the body, while generalized is all over the body. So when it comes to pathogenesis of vitiligo, we know that it's an autoimmune condition. This is because of the immune cells attacking the melanocytes, and this is mediated by cytotoxic T cells and also autoantibodies. Contributing factors, of course, are genetic predisposition, oxidative stress, intrinsic defects of melanocytes, neural mechanisms, and environmental triggers. So this is a model for the pathogenesis of vitiligo. There we have the melanocyte, and then we have intrinsic risk factors. That's where the genetic risks are there. And then environmental factors like oxidative stress will be exerted on the melanocyte, and the melanocyte will release those endoplasmic reticulum stress to the outside. So this will stimulate the immune system, and it's a cascade, and now autoimmune cells will be released in form of cytotoxic and antibodies, and this will now attack the melanocytes. So vitiligo is usually associated with other autoimmune diseases. Most common associated autoimmune disease is the thyroid disease in 15% of adults and 10% of the adults. So this is where your other investigations become very important. It's also associated with pernicious anemia, lupus erythematosus, rheumatoid arthritis, adult onset insulin-dependent diabetes mellitus, and alopecia areata. So when you get a patient of vitiligo, it's very important to rule out those autoimmune diseases, because as we know, one autoimmune disease is associated with other autoimmune diseases. So it's the labs that you request will determine what you're suspecting, or what the patient might actually come presenting with both vitiligo and alopecia areata, or vitiligo and a thyroid disease. And your treatment will also help in taking care of those. So when it comes to management, we have several modalities of management. First, we start with topical treatments, where we use corticosteroids, and then we use calcineurin inhibitors. These are the tacrolimuses and the pimecrolimuses. We also use phototherapy, mostly the narrowband UVB. We use something called PUVA, which is application or intake of a molecule called soralen, which is a phototoxic molecule, and then exposing somebody to UVA, either through the natural light, the sunlight, or through the use of a machine. We also have excimer laser. This is a type of laser which is used to treat vitiligo, the 308 nanometer wavelength laser. So we also use this. Those were the topical treatments. Systemic treatments, we still use the corticosteroids. Of importance is because of all the side effects associated with corticosteroids, we don't use it for long durations. We give it in mini pulses. Like you can give it for, let's say, maybe over the weekends instead of the patient taking every day. We also use immunomodulators because we have seen that immune cascade when it comes to the pathogenesis of vitiligo. We also have nowadays surgical therapy when it comes to treatment of vitiligo, especially when it's localized and stable vitiligo. Stable vitiligo is a vitiligo that has been present for more than 6 months. So we have something called melanocyte transplantation, which is done for patients who have vitiligo. Punch grafting, autologous punch grafting, where a normal skin is taken from the part of the body and transplanted into the diseased part with the vitiligo. And then we have the depigmentation. This is especially for patients who have the generalized vitiligo. Depigmentation, they're given drugs like hydroxychloroquine orally, and then the whole body depigments. So more like what happened with Michael Jackson. So instead of having patches of vitiligo, patients opt to look one color, and this is a treatment that is opted for them, but of course comes with a lot of side effects. They have to really use sunscreens and stay away from the sun and all that. So we have emerging therapies when it comes to treatment of vitiligo. We have JAK inhibitors. Most commonly available in our setting right now is tofacitinib, and this can be used topically for patients and it has good results. There are also drugs which are targeted immunotherapy, which are still in research. Combination therapy when it comes to vitiligo, all these all pigmentary conditions, combination therapy is the way to go. No one drug treats one condition. You can't put a patient on either steroids or calcineurin inhibitors or phototherapy and this problem will get solved. You do have to use multiple treatment modalities, so you can use the topical steroids with oral steroids, with the immunomodulators, with phototherapy, and of course that will have better results for the patient. So vitiligo, as you can see, it has emotional and social effects, so that should not be ignored in the patient. It reduces self-esteem in most of the patients, causes anxiety and depression, social stigma in some communities. So most importantly in your management should also be counseling, support groups, and patient education. So just telling the patient what the condition is, that there's treatment and it will get treated. It's things that can give the patient a positive outlook, instead of, with most patients, they are told this condition is not treatable, it's a lifelong condition, which is not the truth. So prevention and self-care, of course, most important is use of sunscreen regularly. With vitiligo, you have a depigmented patch of skin, you don't have melanin, so your skin is more predisposed to getting skin cancers. So use of sunscreen religiously and regularly is very important. Avoidance of excessive sun exposure. With the sun, it's a two-sided sword, because sun exposure sometimes helps to repigment. As we know, when you're in the sun, you easily tan. So that can help repigment some of the unstable vitiligo, but that should also be limited. People should not go to the beach and tan. Just like 15 minutes of playtime for kids should be enough. And then the rest of the day, they have their, of course, sunscreen applied. Protect skin from injury. There's a phenomenon called Kammp phenomena. You might not have any vitiligo, but if you have an injury to your skin, maybe you had, or even scraped by a tree sometimes, you might develop vitiligo. This is called Kammp phenomena. So protecting your skin from injury is also very important. Maintaining a healthy lifestyle habits, and of course, regular follow-up with a threatening. It's a disease which has a very insidious progression. Early treatment in outcome, and many patients achieve remission. Next, we're going to talk about melasma. We'll discuss the epidemiology, pathogenesis, clinical features, diagnosis, treatment modality, and the recent advances in treatment. So melasma, as you know, or cloasma, also known as mask of pregnancy, is an acquired chronic hyperpigmentation disorder characterized by symmetrical brown to gray-brown macules and patches with irregular outline occurring predominantly on sun-exposed areas of the face. So we're going to see that it's not only on the face, it can also occur on the arms and the chest, melasma. Okay? So key characteristics is melasma is a chronically relapsing condition. It's symmetrical distribution. It's more common in women, 90% of Hispanic, Asian, African, and Middle East descent. Most common location is the face, as I said, followed by forearms, and it has significant psychosocial impact as well. So the global prevalence is 1 to 50%, depending on the population studied. Women, of course, account for the majority, and most affected type of people with skin Patrick types 4 to.
Some of the comments I received, where's fanya kazi ya mzee? That's because my husband is also a surgeon. He was already a surgeon at the time. So this is something someone told me, where's fanya kazi ya mzee? The other one asked me, why are you doing surgery? Do you have something to prove? Tena with an attitude. Another one told me, when I told him that I wanted to become a surgeon, a breast surgeon, because I believe women need to have access to female surgeons, he told me women would not trust to come to a female surgeon. And believe it or not, all these were male Muslim women, male Muslim doctors who told me this. There's no non-Muslim who told me these comments. The others were very supportive, but unfortunately, this came from our colleagues. I'm happy to say that some of them have already brought their relatives to my clinic. So what do you say to that when someone gives you such comments? What do you say? What do you say?
Thank you for your comment.
Thank you. Yeah, I didn't say anything. I just kept quiet, because sometimes when someone tells you you can't do something, you just have to do it. You don't have to tell them, no, nitafanya, nitakuonesha. No, it's more of, let me do it and I'll show you how it's done. And that's what I did. So one of the other challenges that we face in the surgical field, be it in surgery, anesthesia, obstetrics, is the attire, the theater attire. We know that the scrubs are pants and tops and they're short sleeves, and we may not be able to cover the entire arm. That is because of infection prevention control measures. And so you are left with asking yourself, so how do I remain covered? How do I remain as a Muslim woman who covers herself properly, but still maintain the IPC protocols? It can be a challenge. The other aspect is the hijab. While we here in Mombasa are in an environment that is acceptable of that, but in other institutions within the country or abroad, they may not be okay with you going in with your regular hijab. So these are the scrubs that we have. Then you're supposed to, on top of the scrub, you have the cap that you're supposed to wear, but we know most of the time it never fits. But, so these are some of the solutions. Yes, I decided to put my picture there. So this is the hijab that I use in theater. It's not this regular hijab. It's a hijab that it holds nicely, and then you can tie it behind your neck. So your hair, your neck are all covered, but nothing is hanging. So, because the issue is more of the hanging rather than the hijab itself. It's the hanging of these bits that can transmit any microorganisms. So this, I found it very useful. If we look at this other one, so this is something called an orthopedic hood. It's found in some hospitals, not in this country, but abroad. So it can act as a hijab. They don't wear it as a hijab, but they wear it because it protects them during orthopedic procedures. So if it's something that we can have access to, I think it would be good. And then we have the scrub jackets that many of our anesthesia colleagues wear in theater. But now, unfortunately, if you're the one operating, you cannot be wearing this. You have to wear the short sleeves because we know how we have to scrub all the way up to the elbow. So I guess, I mean, religiously speaking, we can be excused. So as healthcare workers, I will not say as surgeons, as healthcare workers, we tend to play many roles. We wear so many hats. We are the doctor, we are nurses, we are mothers, we are wives, we are daughters, we are sisters, we are cousins. And all these people require our attention, our presence, our contribution, and it can be overwhelming. So Dr. Janbibi started us off, and I just kept saying, yes, 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 that one, that one. So we have family obligations. We have parents who need us to take care of them, who need us to take them to their doctor's appointments, to just be present and give them our company. We have children that we have to prepare meals for, we have to attend school functions, we have to buy things from the stationery because they're needed the next day. And in as much as Dr. Janbibi talked about dividing roles, but let's be realistic. No one wants to hear that. You are the mother, utafanya yote. Your school meeting, you're the one who has to go. Kids need sijui what, you have to be the one to do it. No one else will do it for you. And then we also have our religious obligations. We struggle to maintain a good aspect of ibadah. If I ask how many of us managed to finish the Quran in Ramadan, personally, I did not manage. And it feels really bad. You hear of other people wamemaliza khatma sijui 3, 4, you wewe hiyo moja una struggle nayo because of so many things that you're doing all at the same time. You can have this schedule. I think it's very relevant. It's very common among all of us. You have all these things that you as one human being are supposed to do. You have a never-ending to-do list, and it never ends, and it never gets done because an emergency comes up, a patient decides to go into labor, and a patient gets a complication that you have to attend to, then you end up not being able to do any of these. And Dr. Janbibi talked about AI. Maybe you've noticed I've used a lot of it to prepare some of these images. It helps, by the way. I just gave it the prompt and it, let me be honest. So many people look at us and see, wow, she has it all. She's a surgeon, she's a wife, she's a mother, and she's doing it all. What an amazing woman, you know? But do we really have it all? Is it a reality? What do we miss? We miss family events. We live in a society where every day someone is either dying, someone is giving birth, someone is getting married. There are some other family functions that have maybe they're not very well defined. People just decide to get together and do something, and you end up missing many of those. Of course, it helps when the family is understanding, but some family members, especially maybe your in-laws, may not be very understanding. School events, obligations to parents. Like I said, we have parents who need us to take care of them, spend time with them, take them to appointments, just be there for them, and we may not be able to do it to the level that we are supposed to do it. We have school events. Mara, there is assembly that you have to attend. There is this function that you have to attend. Then you have 3 kids. Now I have 3 kids. Each and every one of them has different events that you have to attend to. And you find yourself in the middle of the clinic, and then you're getting a phone call, where are you? You're supposed to be here. And it's just very distressing. You miss bedtime. You miss story time. Just the other day, one of our colleagues who's an obstetrician, she had an emergency and she was very late to be there for her kids, and she mentioned that to us, like, please mention it as one of the challenges. So it's really, it affects our mental health. Time for ibadah is also significantly affected, because now you have to choose, what do I do, what do I leave? Adequate sleep. We all suffer from all sorts of sleep disorders because of the kind of work that we do. Mara, you're getting a phone call in the middle of the night. This woman is having low abdominal pain. The other one is bleeding. One is just in pain. Or sometimes patients just call you in the middle of the night to ask for an appointment. Oh, yes. Oh, yes. I get phone calls at 10 p.m. asking me if they can come see me. When can they come see me? It's not that they're having an emergency. No. They're just okay. But they decided to call me at 10 p.m., asking for an appointment or just sending an ultrasound and then asking you, please have a look and tell me what you think. So, yeah, these are issues. So because of this, we suffer from a lot of guilt. And our personalities tends to be that type A personality where we want to do everything perfectly. We want to be there, we want to be present, we want to do our job very well, we want to be very good mothers, we want to be very good wives, daughters. Each role, we want to perfect it, but unfortunately, it's not possible. So with all those challenges, Sasa, what is the benefit of becoming a female surgeon, surely? The most important benefit is preserving the dignity of patients. Many patients truly struggle to go to male doctors, especially when the issue affects their private parts. Things like urology, breast, obstetrics and gynecology, all or perianal conditions, which are very common in women, like hemorrhoids, anal fissures. So they find it extremely uncomfortable to go and expose themselves to a man. Like I said, that one of those other doctors, they brought their relative to me because they had a breast issue. So they didn't take them to the male doctors. They brought them to me because I am a fellow female. So and when you do this work, you realize how important it is to be present, to be there, to actually do these specialties. And interestingly, when they did studies on the outcomes between male and female surgeons, they actually found that female surgeons have better outcomes, less mortality, and more patient satisfaction. I will not go into detail about that, but these are the observations. So I think it's a good thing. So how do we cope? So we want to do it, we have challenges, we want to do it, and we know the benefits. So how do we cope in these specialties? One, it's very, very important to have a very strong support system. We are lucky to be living in a community, a society that supports this sort of community model. Even though right now the families are more nuclear, but we still see these examples. Like when I went for my fellowship in the UK, I was there for a whole year. My kids were here, but my neighbors were my kids' family at that time. They would take them out. When my daughter got her first period, my neighbor was the one who took her through things, as well as her teachers in madrasa. That's where Ustadha Nafisa teaches, so they are the ones who took care of my daughter in my absence. When my kids needed things for school, because another neighbor has her kids going to the same school, so she texted me, she's like, it's okay, I know you're there, so I'll sort you out, I'll sort out Harith, so you don't have to worry about it. So we still have that sense of community, and that is one of the things that gave me peace of mind, knowing that my kids are well taken care of. So having a strong support system also includes having a good nanny. Please invest in a very good nanny and pay her well so that she takes good care of your children in your absence. Delegate. Delegate, delegate, delegate. You don't have to do everything by yourself. You can't say, this has to be done by me. Hii chakula lazima mimi ndio nipike. No. Imagine you don't have to. Don't do anything that does not require your physical presence. You have to be there for the school events. You need to be there during your quality time with your kids. So if it's a choice between playing with your child or cooking, please play. Leave the cooking, order, do whatever it is, but be there for the child. And we are also lucky to have access to deliveries. We can just make phone calls and things are delivered. We have Glovo. We have so many options that we can utilize. And then there's compartmentalization. Now, in this digital era where you inevitably take work back at home or take home to work, we have to actively make an effort to compartmentalize. Ukiingia kwa nyumba, if you're at home, if you're sitting with your children, put the phone away. If you know you don't have a woman that's in labor, then you don't have to have that phone close to you, probably. So that you're able to focus with whatever it is that you're doing. If it's with time with your spouse, if it's time with your children, your family, you are at a family event, please keep the phone away. And then have dedicated me time. This is where we all fail. We tend to do everything for everyone else, our patients, our families, our friends, our kids, but we forget ourselves. And personally, I have become more intentional in this, where I take myself for a spa date. I just take myself to the salon. I don't want to talk to anyone. I don't want anyone calling me. Let me have that me time. Or I go out with friends, or I have like gatherings with my cousins, no kids, and in fact, I tell them, I don't want any kids in this outing, in this gathering. I don't want anything. And they're not in the healthcare profession. So you know how when we all meet up, even if it's a social event, we still end up talking about this patient and that patient and your boss and the CEO and yeah, so I personally try to avoid to have social gatherings with all due respect. Siko ubaya, but you understand. It's because we don't talk about anything else. But when you're with other people who are not in the healthcare profession, you will not talk about your work. So, I'm good with time. So, our why. Eventually, we have to, in whatever we do, we have to purify our niyyah. We have to know why we are doing what we are doing, so that it helps you focus and be able to do right by each and every person in your life. Know your limitations. Know that you cannot do it all. We can't be perfect in every aspect, but we try our best. And when we do our work, we want to do it with excellence. We want to do it with efficiency. إن الله يحب إذا عمل أحدكم عملا أن يتقنه. Allah loves it when you do work, you do it with excellence, you do it with efficiency. So yes, in as much as we strive to become the best in our professions, we also need to not neglect everything else. I forgot one important slide, which is the one before this, which is prayers. This is what keeps me grounded. The fact that me making my own prayers, having a family that supports me this way, and having patience. When you see those good outcomes, even if it's a bad outcome, but the patient is very grateful and they pray for you, wallahi, those are the prayers that are answered. All right? So these are the things that keep all of us, I believe, going. Thank you.
MashaAllah, tabarakallah. Let's clap for her again, especially for keeping time. So the next thing, I want to welcome all the speakers on stage for the Q&A session. So, yeah, we'll bring Rahim. Okay, so we have Dr. Mariam Badawi, Dr. Aisha, and Dr. Jan Bibi. So the floor is open. Anyone with questions? Speaker iko hapa ama mmeandika kwa vikaratasi? No questions. Hello.
Assalamu alaikum. I'm Dr. Rukia. So my questions are to Dr. Janbibi and Dr. Badawi. So Dr. Janbibi, in an era where we parents are expected to do everything perfectly, how can we distinguish between healthy striving and harmful perfectionism? Question to Dr. Badawi. Have you ever felt the need to prove yourself amongst your peers because of your gender and your faith, especially the male colleagues? Thank you.
Thank you, Dr. Rukia, for the question. Perhaps I can pose another question back to you. Apologies for that, but who expects us to do everything perfectly? Exactly. It's a self-imposed expectation or sometimes a societal expectation that you are free. She was not expected to be a surgeon, but she went ahead and said, no, I'm going to become one anyway. I'm going to prove you wrong. So some of these are self-imposed, some of them are societal imposed. Mind you, we are the society. We have the ability to change expectation. We can change the expectation that a parent has to be perfect. No, you don't have to be. You have to try your best, but that is not perfectionism. And most of the time when you do have that personality that everything has to be perfect, not only will you drain yourself of energy, but you will also impose a lot of things on the people around you. You will want your kids to be perfect. So now you will be the one, inflicting that childhood trauma that we talked about. So it's okay not to be the best. It's okay to be good enough. If you've given it your all, that's enough. And honestly, sometimes you just have to stand up and say no. I mean, if it's not haram, there is nowhere in any religious, place that I have to be perfect. I cannot be a surgeon. I cannot be this and I cannot be that. I cannot work. I cannot do this. Then go ahead and say no. And most of the time, these expectations were imposed on us because of the male-dominated society. But things are changing. The world is changing, and we also have to change. I hope that answers the question. Thank you.
So thank you for your question. And the answer is no because of two things. I had two factors that helped me not feel like I needed to prove myself. One factor is having a family that was 101% supportive. So my family, meaning my siblings, my parents, all the men in my family, and it's a big family, mashallah. She'll tell you. So I had no naysayers in my family. And my husband was not a naysayer either. In fact, he's one of my teachers, I would say. Yeah? So that gave me that confidence that I can do this. And no one doubted that I couldn't do it in my family. No one doubted that, no one said that, are you sure, but this is more for men. No one mentioned such things. So it was never in my head that maybe this might be a problem. The other factor is, I think my upbringing, I grew up in Saudi Arabia. I was the only Kenyan in school. And then I graduated there. I went for medical school in Egypt. I was the only Kenyan in the entire university, not in my class, in the entire university, all faculties. So I think I had that idea that if I was the only Kenyan in school, the only Kenyan in my university, and I did well, I can be the only female in this field. So what? That's it.
Takbir. Any other questions?
Dr. Aisha, thanks for your question. I'm Dr. Sade. I mean, in Kenya, every town you go, it's flooded with cosmetics. All the shops, women are, smothering themselves so much. What advice do you give to this forum? Like, which are the safe cosmetics and which ones are not? Because I really fear that maybe there are lots that are causing harm. Yeah?
Okay, so assalamu alaikum. Thank you, Daktari, for your question. Yeah, so cosmetology or cosmetics has become a market income for a lot of people nowadays. So many people call themselves doctors, cosmetologists, estheticians, and we have a lot of outlets that sell a lot of products. Partly to blame is the government that allows them to bring in these products without any monitoring. But the most important thing to do is, I think, is to get your consultation done by a professional. Not everybody that calls themselves doctor or a esthetician is qualified to give you that advice. So the most important thing will be to visit a professional. Either, of course, there are so many dermatologists nowadays, it's not like before. The skin products, I think the most important place to get your skin product as well is outlets like Pharma Plus, Good Life, Health You doesn't sell. But those outlets are better than the shops in Marikiti, for example, where you can get your stuff. So, yeah, I think those are the most important things, to visit a professional, certified doctor, to get your consultation done and get your products from an outlet that has legit products. Because also these cosmetic products, the sunscreens, the moisturizers, the ones that are sold in the normal shops are not up to standard. They are not the right creams. They're wastage of your money, more or less. So I think buying them from trusted outlets is the most important thing, instead of buying them from shops where they sell maybe cheaper. Yeah, and I think that's my answer.
So we are taking one more question.
Assalamu alaikum. My name is Dr. Nadia. Thank you all. It was a lovely presentation. My question is to Dr. Aisha. Adding on to what Dr. Sada was talking about, I'm more concerned on retinols and retinoid derivatives. As an ophthalmologist, I think I've noted we know that they cause idiopathic intracranial hypertension, which we have been seeing a lot. I know mostly it's with the systemic derivatives, but there are several case reports that people have reported on topical. So, with the age group that uses these products, which is also a risk factor, I don't know how you can advise on that approach, whether people can use and monitor, maybe as you can advise us.
Okay.
Thank you.
So thank you, Dr. Nadia, for your question. Okay, so retinoids, as Dr. said, yes, it has side effects of causing hypertension in, of course, patients with risk factors. Retinoids, for those who don't know, are gold standard when it comes to treatment for acne. They are also gold standard for treating they're anti-aging. They're in a lot of the anti-aging regimens in the market. So there's topical and there is systemic use of retinoids. So we use systemically to treat acne, severe acne, and other conditions. So what we advise patients is, of course, they have to do some lab works. We have to take a complete history to rule out whether they have hypertension, history of hypertension, and all that. So the most important thing will be to do that for your patient, and then also monitoring your dosage for taking the retinoid, the isotretinoin.